everybody. Welcome to another weekly episode of the Scoliosis World podcast. Of course, I'm your host, Dr. Mark Morningstar. Thank you very much for tuning in this week. We're going to dive right in. We have a very educational topic this week, and really it's going to be, I suppose, the main theme of the show is what I always refer to as the myth of curve-centered care. And really what that means in a nutshell, and I'm going to kind of use a lot of research today to back up what I'm saying, is that if you're doing some type of a scoliosis treatment plan, whether you're a patient participating in a certain physical therapy routine or wearing a brace, or maybe you're looking into surgery, or maybe you've already had surgery. If you're only physically treating the curve, your treatment is eventually not going to last. And I know that sounds odd to say, especially in people who've already had the fusion surgery. But the reality is that a fusion surgery doesn't solve the condition. More specifically, again, I don't care if you're doing a physical therapy routine. I don't care if you're wearing a hard brace. I don't care if you've had fusion surgery or tethering or any ApiFix, any of the surgical interventions. By only treating the curve, you're not addressing the underlying reasons as to why that curve is there in the first place. And so all you're doing inevitably, no matter which of those treatments, non-surgical or surgical, that you're doing, those treatments are really only temporarily pushing back the set point of your curve. So on the low end, maybe you're participating in an exercise-based kind of a scoliosis-specific rehabilitation program. Pick any of them. If you're wearing a brace, maybe if you're doing one or both of those, maybe you're improving the curve 10, 12, 14, 15 degrees. Maybe you're just keeping the curve stable where it's at say 30 degrees. Either way, when you're done participating in those treatments, you're still left with an existing curve. Over the course of the rest of your life, that curve is going to slowly advance and worsen over time. And then there are downstream life stages where those curves can actually worsen on a more rapid basis at shorter intervals, like during pregnancy, for example, and then also at perimenopause, or in males in andropause. So there are times where the curves still worsen over time. So even if you've had surgery, patients who have had tethering or scoliosis fusion surgery, whatever it is, maybe now they're correcting their curves in half. So they had a 50-degree curve. Now they have a 20 or 25-degree curve corrected down to with the surgery, but they're still left with a 20 to 25-degree curve. And that curve is still going to slowly advance over time. Here's why. There are reasons as to why that curve develops. That curve is caused by hormone problems, genetic predisposition, neurotransmitter issues, digestive-related problems, nutrient malabsorption, bone density differences or deficiencies in certain senses. If none of those things get addressed when you're a child and your curve is newly discovered, typically in adolescence, well, guess what? Those things don't just magically go away because you became an adult. And those things don't just magically go away because you solved the curve or you improved the curve, no matter what means of treatment you participated in. So the goal becomes, I think the better management strategy of scoliosis has to start with dealing with the underlying reasons as to why that curve is there in the first place. Now, this is going to blow your mind. So again, I told you I'd bring research with me here, right? So I'm going to go all the way back to 1977. Now, just to give you an idea, I'm 50 years old. This study came out when I was 2 years old. Okay. This is written this is published in the journal Clinical Orthopedics and Related Research, very prominent orthopedic journal. Written by Paul Harrington, the medical doctor that created Harrington rod surgery for scoliosis. The guy, right? 1977 writes, research in molecular chemistry, enzymes, coenzymes, genes, proteins, hormones, etc., at last is beginning to reveal secrets to those who have persevered in the laboratory. It would appear that a relatively minor deficiency in the disc collagen can cause idiopathic scoliosis development in the spine. A nutritional deficit during the vulnerable growing years, i.e., hormonal influence, may initiate the scoliosis process, with genetic tendency being a recessive factor. Thereafter, given the initial deficit, the spine has no choice. It must react to force, meaning gravity, time, and direction, and ultimately produce scoliosis. This is Dr. Paul Harrington in 1977. Nobody is doing anything about any of these, right? That's the problem. 50 years later, nobody is doing anything about these clinically. Well, except for a few of us, right? Now, you'll hear a common theme among all of my Scoliosis World podcasts and probably everywhere I talk, even to all of our Back Genius doctors who are in the Back Genius network. You're going to hear me talk about this time and time and time and time again. Genomics, or genetic predisposition, is the name of the game and will ultimately prove to be the X factor in either outright preventing scoliosis from occurring or minimizing the chance that scoliosis will worsen across the lifespan. So, with that in mind, I'm going to kind of share with you some data to kind of go through and say, okay, this isn't just Morningstar's opinion. I'm giving you evidence as to why this is important to tackle. So, again, let's kind of go through this here. This is exploring the association between specific genes in the onset of idiopathic scoliosis, a systematic review. Again, from a research design perspective, the single most powerful study design there is, a systematic review. In this particular study, they looked at 24 total studies that are all gene-based scoliosis studies in nearly between scoliosis patients, 16,000 scoliosis patients, 81,000 control patients, and compared them and showed a number of genes all relating to either calmodulin production, which is a hormone, estrogen receptors, bone density, and vitamin D receptor malformation. All of these are related to idiopathic scoliosis development or progression. And this is in a systematic review. And this is published in Biomed Central's Medical Genomics 2022. And these are researchers out of Italy. So again, everybody is coming to recognize that genes are important in the onset and or progression of scoliosis. Fast forward. This is, actually I'll go to this one first here. Epigenetic and genetic factors related to curve progression in adolescent idiopathic scoliosis, a systematic review of the current literature. Again, most powerful study there is. And I'm just going to read to you right from the author's remarks. Prognostic testing for adolescent idiopathic scoliosis has the potential to significantly modify scoliosis management. Most recent evidence suggests that epigenetics is a more promising field for the identification of factors associated with idiopathic scoliosis progression. That's huge. Now, a lot of people, especially over the last 8 to 10 years, have been trying to figure out ways and calculate ways of guessing and predicting curve progression in people who already have a curve. However, most of those models are almost 100% biomechanical in nature. For example, SOSOR a few years ago published what's called a progression factor. And that progression factor uses demographic info and radiographic info to determine the risk of curve progression. Things like the patient's age, their riser sign, and their current Cobb angle measurement. They're using those factors to determine what is the risk of progression? Well, forgive me, but there are a great many other things underneath that curve that are probably more accurate in terms of predicting curve progression. Because the problem with the progression factor alone is once a child reaches adulthood and they're done growing, that risk of progression score drops. And the trouble with that is we know for a fact that curves progress throughout the lifespan. Now, they happen at different rates for different people. And some of that depends on what their curve measurement is at once they hit skeletal maturity, but it's always there. And so it's really become quite obvious, frankly, that genomics and epigenetics play a huge part in trying to predict curve progression. But to take that a step further, I think at the end of the day, the real goal is not to just assess the risk of curve progression in somebody who already has a curve, but I think we're on the cusp of identifying how can we use the same type of genomic risk and epigenetic expression to predict whether or not a certain child who doesn't yet have a curve will ultimately develop a curve if you don't do anything to mitigate those genomic and epigenetic risks. So to take that a step further then, and this is a very new paper. This is from, I'm sorry, not that new, 2021. But just to give you an idea, this is the polygenic risk score of adolescent idiopathic scoliosis for potential clinical use. This is the Journal of Bone and Mineral Research, 2021. And of course, I'll have my editor put that up there. Thank you. Quite literally, I'm not even exaggerating here, there are 34 authors on this study. From all over the world. Typically, majority of them are from Japan, Taiwan, and actually that's it. Japan and Taiwan. 34 different doctors and scientists. So basically what they did is based on certain genetic correlation, they accessed genes from the what's called a genome-wide association study. So from Human Genome Project, comprising 79,000 subjects and 32,000 female scoliosis patients. And what they did is they created what they call a polygenic risk score for predicting both the onset and progression of idiopathic scoliosis. And what they showed is that both the onset and progression of idiopathic scoliosis share a similar risk score range. So you can use genomic assessment to predict scoliosis onset in somebody who doesn't yet have scoliosis. I do believe in my heart of hearts that at the end of the day, when this all gets figured out and people figure out how to incorporate this into clinical practice, that it will be far, far easier to prevent scoliosis from happening than it will be to treat an existing scoliosis, no matter how severe the curve is. And honestly, that's one of my own personal ambitions, is to really sort of finally solve the puzzle and figure out a way to predict onset in a very, very consistent fashion. And I believe some of the easy targets of this are children who are born to parents where maybe one or both parents had scoliosis or has scoliosis. A sibling, an older sibling has scoliosis. Maybe a grandparent or multiple grandparents have scoliosis. Those are the easy ones because there's already an established family history. But even in patients where there isn't a known family history, and now that child is inheriting different genomic risks and genomic variants from both mom and dad, who they themselves don't have scoliosis, but because that child inherits a confluence of the genes from mom and from dad together, now the confluence of that inheritance pattern can result in a curve during a time of rapid growth. And again, those are your genes, right? So gene variants don't just go away because you became an adult. So I think it's important to look at this from, if you have the genomic predisposition to developing scoliosis, I think it's important to look at that and say, here are the things that you can do to help ensure that you don't develop scoliosis, not only as a teenager, but later on as an adult, as a pregnant adult or a postmenopausal adult, whatever the case may be, that you are doing all of the day-to-day lifestyle, dietary kinds of things that can minimize the chance that you develop a curve during various life stages. All right, to give a little bit more associated on this, or light on this, International Journal of Adolescent Medicine and Health, 2023. Overview of adolescent idiopathic scoliosis and associated factors. And again, a review paper. This study used nationwide databases to describe the prevalence of adolescent idiopathic scoliosis and associated risk variables. The current review showed that idiopathic scoliosis was significant worldwide and that gender, physical activity, body mass, backpack carrying, and backpack weight were all significant factors for developing AIS. Again, these are all mechanical in nature. Now, I applaud the authors because, again, anytime you can try to develop algorithms, calculations, identify trends that can prevent something from happening, we should all be 100% in favor of that. Now, I would say, however, that this particular study comes a little bit short because it's only taking mechanical or biomechanical factors into account. Nothing genomic, nothing hormonal, nothing neurological, etc. Speaking of neurological, 2023 Neurochirurgia, which is an English edition journal, PubMed journal, Neurological Mechanisms Involved in Idiopathic Scoliosis, systematic review. In the neurological response to idiopathic scoliosis, the sensory cortical integration of afferences, I'll explain what that means in a second, in the visual, oculomotor, vestibular, proprioceptive systems allows modifications at the postural level in order to achieve an initial compensation of the centers of body mass. However, over time, these compensation mechanisms may be exhausted, causing progression of the initial postural deformity. Put that into English for you. For a long, long time, I have taught and still teach to this day to my patients, when I look at an x-ray of a scoliosis, lumbar curve, thoracic curve, doesn't matter where. Of course, orthopedically, we're looking at a curved spine, skeletal frame, etc. However, neurologically speaking, what we're looking at is we're looking at the brain's internal map of what it believes that person's normal postural muscle control and postural coordination and integration should look like. Whether it's normal or abnormal, it's just what the brain perceives to be normal. Okay? Now, what they're saying is that what we know, and we know this to be true in about 88% of patients who develop idiopathic scoliosis, is that they have asymmetries or imbalances in the muscles around each of the eyes, as well as the sensory function in the inner ear on both sides, which is what helps us maintain our balance and so forth, as well as the sensory function in the top 4 vertebrae of the neck. So when we run into that, the problem is those areas also have to be treated, because if we have an asymmetry of the information, for example, from the muscles around one eye versus the other, now the brain has to try to make sense of that, and there becomes a normal delay. And that's where postural discoordination sort of becomes a problem. Well, sometimes that curve that we have in the spine starts out as a postural adaptation to the asymmetry of information being provided by the muscles around the eyes, vision itself, neck sensors, inner ear sensors. And when the brain is having to make heads or tails of all of this information coming in, it now adjusts posture in a way that it thinks is proper to balance the head over the torso over my tailbone. And in some cases, In order to achieve that vertical balance, a curve has to develop essentially as an adaptive response to the malfunction or the asymmetry of that neurological information. What's interesting about this is that a lot of these neurological asymmetry problems that we notice in scoliosis are, guess what? Genomically predisposed. So we can test for this. So if a child has these neurological mechanisms being affected by genomic variants and inherited traits, now we have the opportunity to intervene with these things and work on these things long before the curve ever develops, in the hopes that now, as the body can start to get these systems retrained, get them balanced, get them to produce more symmetry of information, again, maybe the curve never develops in the first place. That would be sort of a functional neurological application of how to best potentially prevent scoliosis from happening. It's not just about taking nutrients. It's not just about changing my diet. It's not just about sitting a certain way all the time. You have to address all of the manifestations that all of the different gene variants might contribute to downstream. Some of those things require physical treatment in and of themselves, like a lot of these neurological asymmetries. But in doing so, it helps improve our odds that by treating a patient who doesn't yet have scoliosis, and we are now essentially addressing every single potential variant that that child has that could be related to the onset of scoliosis, now the hope is they never get scoliosis in the first place, especially during their growing years. Now, again, going back to the idea that genomic variants are permanent, we can't fix them. Obviously, the most important time for scoliosis onset is during the teenage years, during puberty, and our main growth spurt. That's not to say that a curve can't develop later in life, because it can. But at least now that we've identified the genetic predisposition, well, guess what? Now we've given that patient the tools and the arsenal available to be able to stay in control of the situation well into adulthood. So that eventually when they are pregnant, or they are in andropause, or they are going through menopause, and now they're post-andropause, post-menopause, these mechanisms are now not going to as easily result in a curve as we could have been if that person had just ignored it entirely. So that is the single crux of this podcast episode. It's genomic prediction, genomic prediction, genomic prediction. That comes in a couple of manners, though, and I've talked about this in previous podcasts. There's an epigenetic expression to these genomic variants, meaning it's not enough for me to just inherit one of the genes to develop scoliosis. I also have to have the right other environmental expressions. Now, what I would add to that is that there is no one singular gene that causes scoliosis. We know that. However, if I inherit this gene that makes it easier for me to be progesterone deficient, and I inherit this gene that makes it easier for me to be vitamin D deficient, now I have two potential variables that directly impact my bone density development when I'm a teenager. Well, obviously, I want to address those things. So I need to do that in the best way possible. That person, those genes, that vitamin D problem, that progesterone problem are never going to change. However, we might be able to entirely eliminate their impact on that person by doing things like putting them on pregnenolone, or putting them and having them take vitamin D, or having them sit in front of a blue light for sunlight exposure, or the same wavelengths that cause your body to produce vitamin D3. Those are easy strategies that we can employ to make sure that those particular gene variants aren't having a downstream impact on that person's chance of developing a curve, or at a very minimum, allowing a mild existing curve to increase to a point where now surgery or bracing or some type of a conventional treatment becomes necessary. So, and again, nutrient therapies do play a substantial role depending on which of these gene variants that person might have. For example, and I've referenced this before in other studies, but there is a study published out of Romania where they were able to show that taking melatonin, vitamin D3, and calcium was a significant enough treatment that it could minimize and in many cases negate the curve progression of children who were newly diagnosed with mild curves, compared to children who had the same curves who just did nothing and saw their curves progress to a treatment necessity, meaning 25 to 30 degrees. Whereas the kids who just took the nutrients and that's all they did, their curves didn't worsen. Well, guess what? When you take melatonin, there are gene variants that make it easier to be melatonin deficient. Guess what? There's a gene variant that makes it easier to be vitamin D deficient. Guess what? There's a gene variant to make it easier to have calcium absorption and utilization problems. Well, it's probably not a coincidence that if I'm taking those nutrient therapies, the kids who have those genetic risks are going to be positively impacted by taking those nutrients. So I'm not surprised that that study would conclude that and show that. So, because bone density problems are part and parcel to scoliosis. And again, going back to what Paul Harrington said, 1977, they're saying flat out, let me find it again, nutrient problems are the main driver. Let me read it for you again here. Where did it go? A nutritional deficit during the vulnerable growing years, i.e. hormonal influence, may initiate the scoliosis process, with the genetic tendency being a recessive factor. This is Dr. Paul Harrington, 1977, saying this. 50 years later, we're still only at where we're at. Now, some of that's the limitation of genetic testing. I can appreciate that. But each factor is known to cause scoliosis. Nutrition, hormonal influence, genetic tendency, and spinal biomechanics. You have to look at all of those to be able to predict the onset of curve onset initially, but then also curve progression, risk of curve progression. Well, it's not enough to have just a model looking at genomics. It's not enough to have just a model of curve progression or prediction of curve progression based just on biomechanical factors or a polygenic risk score just based on genomics. You have to have a blend of the two to have the most robust idea and most accurate value of how you can assess the risk of developing a curve. And that's exactly what I'm tackling. So the cool thing is that I think it won't be too long before there is a test available that will be able to show and predict whether or not a child who does not have scoliosis, but has all of the mechanical and genomic risk factors for developing a curve, that we can then show, we can consistently test for the accuracy of that. And B, when we identify a patient who is at risk, we can now consistently treat them and get a consistent ability to stop that curve from ever happening in the first place. And it gets me very excited to know that we are on the brink of that. So, and that's one of the reasons as to why Back Genius was started. You know, everybody sees the little Back Genius logo here up at the top of the screen. Well, Back Genius is a network of doctors who, like myself, are really operating under the sole idea that we are trying to do absolutely everything we can to manage scoliosis and treat scoliosis in the most comprehensive manner possible. I don't care what tools we use. I don't care how we get there. The goal is to have the biggest, most robust, most comprehensive scoliosis management plan, period. Because not only does that help us more effectively treat curves and get better chance and have a better chance for curve improvements consistently, but it also helps us to make sure that whatever improvements we get in the curve are more likely to stay long-term because we're addressing these underlying factors. But then additionally, we're about identifying a child at risk for rapid curve progression. Maybe an exercise or bracing program isn't right for a particular child because their genetic risk is so high, it's not going to be worth it for them to go through the physical treatment of exercises or bracing or both, because they're still going to end up at a surgery threshold anyway. Why waste that child's time, money, and effort, or that family's time, money, and effort, and frankly, my time and effort, knowing that child's going to fail treatment in all likelihood? We can get them then to surgery, and in the meantime, still address the underlying curve progression and curve onset factors, genomics, lifestyle, etc., so that when that child does have surgery, we now can basically reinforce the odds that the results from that surgery will now last a lifetime, not just the next 5 or 10 or 15 years. And then to make it a step further, With Back Genius, we're all about trying to assess the chance that a curve is going to start in a child who does not yet have a curve, and then have the ability to treat it and mitigate it right before the outset in the hopes that that child never actually develops a curve. And we are on the cusp of that, and it's very, very exciting. So if you have any questions, if you are interested in this type of management approach for yourself or a loved one, feel free to reach out to me personally. My practice website is scoliosispractice.com. You can also email me. My email will be down here at the bottom of the screen. I can also put links to the clinic website and links to Back Genius down in the comment section for the podcast. You are more than welcome to reach out to me personally for a free x-ray review, free consult, see if this type of management strategy is right for you or your loved one. And as always, thank you for tuning in. If you like what you're hearing on this podcast series, please, please, please subscribe below. I would love to have you here. And I appreciate you tuning in every week. And we're coming up on Christmas here. There's going to be one more episode here up until Christmas. So we'll have a special Christmas episode probably here next week. Otherwise, we'll see you next time. Thank you for tuning in. I'm Dr. Mark Morningstar. Again, reach out if you need to. Thank you.